We're going to move on to our last talk of the day, which is Tom Yankeelov from University of Texas, Austin, who's going to talk about his clinically important digital twin models.
All right, can you guys hear me okay?
You're fine. Go ahead.
That's fantastic. All right, good. I was having some audio issues earlier, so that's great to hear. And that's going to be a tough act to follow, and that difficulty is compounded, of course, by being the last speaker, and everybody's kind of probably done. So I hope that I can keep you engaged, and I'll try to start off here with a shot across the bow. So here, in my infinite wisdom, is what I see as the fundamental issue with clinical trials, right? The clinical trial is designed to identify the intervention that works for the population average. You're comparing groups of people between a control arm and a treatment arm, and you want to see if one group does better than the other. The problem, of course, is that there's no such thing as an average person, right? You can look at a distribution of heights, and that has a nice Gaussian distribution, and weights is similar. But once you start getting beyond these sort of superficial metrics, there's really not an average person. It's not a Gaussian distribution once things start to get more complicated. So at the risk of being really obnoxious, if you find a therapeutic regimen that works best for the population average or for everyone in general, you're going to find a therapeutic regimen that works best for no one, almost by definition. So, of course, statistical inference is super important. It's enormously powerful, but it does rely on properties of large populations that can obscure conditions that are specific to the individual. So all the comments we've been hearing about mechanism-based models are things that really that I really appreciate. These high consequence decisions we make in medicine, and in particular in oncology, where heterogeneity rules the day, they got to be based on more than just data analytics, right? So how do we do this? So what our team does is we try to do this. We have this approach where we try to get four-dimensional data, 3 of space and 1 of time, that tells you some key characteristics about how a tumor is changing in space and time, about its dynamics, okay? And then we try to build a mathematical model that can be calibrated with that data that was acquired on the individual. So that's going to be a reoccurring theme for us, is that we try very hard to calibrate our models using data that's just available on the individual. The question that Tomas mentioned in the previous thing is, how much data do you actually need from the individual? How much can you learn from a population to guide your patient-specific prediction or intervention? Boy, that is critical. We have this naive view, perhaps, that there's only so much you can learn from the avalanche about the snowflake. You really have to pay attention to the individual. All right, so you get your 4D data, 3 in space, 1 at a time, track some key characteristics of a tumor, then build a mathematical model that relies on those characteristics from the individual. You calibrate it with that data, and you make patient-specific predictions. So we're not looking at population trends here. We're trying to capture the heterogeneity at the individual level. So our data types are things that are really commonly available for all solid tumors, right? We're looking at here an MR image, of anatomical image. Tumors right here. This is a breast tumor, nipple B here, chest wall is here, heart's peeking into the field of view here. So this gives us our computational domain. We can use this to segment the tissue up into healthy tissue, fibroglandular, adipose tissue, and then the tumor itself and subcomponents of the tumor. We make these diffusion weighted measurements to give us an estimate of cell number throughout the region of interest, and then a map of perfusion, right? So there's other measurements as well, but these are the ones that I'm going to focus on today. And these things are kind of available in basically every MR exam of a solid tumor, so they're not difficult to get our hands on. So in fact, in many of these tumors, these measurements on their own, particularly the cell number and perfusion measurements, those measurements on their own have been shown to correlate and even in some cases predict how how they're going to respond. So the idea is that if these measurements are good, at least in a correlative sense between response and non-response, then they are ripe measurements to go into a mechanism-based mathematical model that's going to try to do predictions in space and time. Okay, so here is sort of just one of the equations that live in our mathematical model. And so it's a partial differential equation, and n is the number of tumor cells at position x and times t. And we're tracking how this changes with respect to time. And so depending on, if you're used to looking at these or not, it might be straightforward to interpret, or maybe it's a little complex, I don't know. But this is a diffusion term, and so it describes how the tumor cells are moving around. We actually couple this to the mechanical properties of the surrounding tissue. I'm not going to talk about that today, but happy to if you want to. Then there's the proliferation term, which we have logistic growth. Tumor cells proliferate in a spatially dependent manner, K of X, up to some carrying capacity theta. That's determined by the physical carrying capacity that's determined by the voxel size in our images. And then there's the treatment component right here that has some efficacy alpha. Efficacy is waning at some beta sub n for the nth drug. And then the concentration of the drug is estimated by the MR data. So on the previous slide, the first image on the previous slide was an anatomical image, and that gives us our computational domain that we're going to, mesh. And then the second one, the one in the middle, was the cellularity map, and so it's giving us our estimate of n. So wherever there's an n on the right-hand side here, we're gonna use that cellularity map to estimate what n is at position x and time t. And then our perfusion map gives us an estimate of how the drug is being delivered. So the key parameters that we need to get our hands on to calibrate for each patient are this proliferation and this alpha. That's painting in broad strokes. The proliferation of the tumor and then how it's responding to therapy. Those are the things. Okay. And so here's just a little quick pseudo video trying to give you an overview of what's happening. So here are measurements of a breast tumor right here over time. This middle row here is going to be our prediction of how this tumor is proceeding in time and space. And then up here, once I hit go, there'll be an image that's moving, and there'll be a blush on it every time treatment is delivered, and that's going to cause a change in the predicted value, and we try to match the prediction to what's going on down here. So every time there's a blush right here at this, there's a treatment, and that causes a concomitant change in the tumor cell number every time through the treatment. That's captured by this term right here. And so the idea is, how well does this row capture to this one? We'll run that just one more time. Every time there's a blush up here, that's when this term is kicking in and delivering a drug. And then down here, that's how they're responding to therapy given by that alpha, and then how it's proliferating and expanding. So if I pull out the end of a single patient right here, the blue here is what we predicted, and the red is what we observed for this locally advanced breast tumor. And you can see that the prediction is doing a pretty good job of matching what the observation is. And in fact, we did this in 130 some odd patients, and the measured volume change versus the predictive has a really tight concordance correlation coefficient, right? This is like a Pearson correlation coefficient with a penalty if you're off the line of unity. So that's the measured volume change. And then here it is, whoops. Oh, yeah. So this is the measured volume change versus predicted. This is using the MD Anderson triple negative moonshot data. So that data is actually really pristine, right? It's all at one place, and the imaging that comes out of Anderson is phenomenal. And you can see these really tight error bars. And then this is using publicly available iSpy data. This is now published in clinical cancer research just a couple of months ago. So it's using the iSpy data, 3 different subtypes rather than just the one triple negative over here. So 3 different subtypes acquired from 10 different sites, and we still can maintain this high predictive accuracy. The error bars are, of course, due to data coming from 10 sites with different levels of QA, QC, et cetera, versus one site with really wonderful data. So we think that we're getting pretty good at predicting how these breast tumors grow both in space and time, at least in the pre-surgical neoadjuvant setting. This is from a single site, and this is from 10 sites with 3 subtypes. So this is now going to other diseases. Here it is in prostate cancer, measured versus predictive, lining up nicely on that line of unity. A much more recent one, this paper has just been submitted on cervical cancer, measured versus predictive. Just a few data points. I think there's maybe, 9 or 11 patients on here. So this is an early effort, but moving to cervical cancer. So there's definitely something generalizable about this model that I had at the top of the previous page. And the key thing here, right, is that we don't need a population to calibrate the model. And every time you move from one disease site to another, we don't recalibrate. The idea is that that mathematical model has things that we know are important to how tumors grow and respond to therapy, things like the mechanical properties of the tissue around it, how drug is being delivered, how the cells are moving around, how they're proliferating, how they're responding. So those things are, of course, important to any disease site. And so we have that model, and we have data from cervical cancer or prostate cancer or breast or whatever, and we use it to calibrate it on the patient-specific basis. So we don't have to retrain the model as we move from one place to another. We just recalibrate the model to each individual patient. Right? That was all for systemic therapy. We've extended it to radiation therapy. So everything up here in this first part is the same as before. The rate of change of the number of cells at position X and time T with respect to time, that change with respect to time, has a movement component coupled to tissue mechanics. Proliferation, there's the drug treatment term, and now we have radiation treatment, right? And so this is measured versus total. There is a systematic bias here, but still not so bad for this complicated disease. And you can, of course, update this. So every time a patient gets a new scan, you can go back and update your model calibration and make another prediction going forward. So this is the measurement of a patient being scanned once a week for 6 weeks. This is part of a clinical trial at Anderson, led by Caroline Chung, our radiation oncologist colleague and friend. And then here is our prediction. And you can compare these two, and you see that there's a pretty good trend between areas of necrosis versus areas of proliferation as you move across the measurement and the prediction. If you look really closely, you can see that our prediction is not as good as we'd like, because it looks like it's lagging behind. So if you compare like the nth data set here with the n+1 prediction, there's a really nice correlation to that. So there's something missing in this model that is not letting us, really nail it. But, in general, using patient-specific data that's readily available, the top row here looks pretty close to the bottom row. So we're pretty excited about that. Okay, so just to summarize that this biology-based mathematical modeling, it's one model calibrated on a patient-specific basis, and you can port it around. You can shift it from patient to patient. So this is brain cancer, observed versus modeled. The dots are the data. The line is the prediction, the modeled. First two are calibrated. The last one is predicted. Similarly for breast cancer, and similar for cervical cancer. So it's the same mathematical model and the same data types for each tumor. It's immediately interpretable and explainable because all the terms in the model you can point to and say, this has to do with how the cells are moving around. This has to do with proliferation. This has to do with response. And the data can come from readily available MRI data. And at the risk of being super obnoxious, and we should probably debate it, I'm positing that this isn't possible with an AI-based approach, because every time you move from disease site to disease site, you're going to have to retrain that model. And this is just patient-specific stuff, which lets you go into powering a digital twin. So I see let me look in the chat here. That might be for the previous speaker. Yeah, okay, so nothing for me.
We're monitoring it for you, Tom. So
okay, cool.
Yep.
Appreciate that. Thank you. All right, so that's all about prediction, and we want to be able to use this to power a digital twin because we want to be able to guide the intervention. That's where we want to get to. All right, so here's a platform for predicting and optimizing treatment response. So the blue stuff is what you might call the physical asset. This kind of thought process grew up in aeronautical engineering, and so they refer to it as an asset. The physical asset is the plane, and the digital asset is the computational manifestation of that on a computer. So the patient presents with their anatomy, morphology, and whatever kind of physiology mechanics they got going on. We'll index it by eye because we're going to iterate on this. You don't just treat once and let things go. You're coming back, and there's multiple opportunities for intervention. Then there's the measurements you make. I grew up through medical imaging, and so we use a lot of different kinds of imaging data for this stuff. And then there's the things that you can do to the system, right? So there's the imaging studies or biopsies, adjusting the treatment. These blue things are all things you can touch and feel and do to the system. Then there's the digital counterpart, the things in red here. So this is your computational domain, your finite element mesh, boundary conditions, etc. One key thing here is this input, so that the treatment regimen. Because if you have a mathematical model that is calibrated to the individual, then you can simulate different interventional strategies for that patient. So here, this is it doesn't really matter, but this is simulating adriamycin, Cytoxan, and Taxol for triple-negative breast cancer. This is adriamycin, Cytoxan, AC, and you give a bolus, and then you wait 20 days, and then there's the second round of treatment. So everybody knows that that's not the best way to give the treatment to the patient, but there's not enough resources and there's not enough patients to explore, in clinical trials or experimentally all the different ways you might want to give that combination therapy. And just off the top of your head, you might say, okay, well, let's take that dose here and cut it into thirds and do 1/3 of the dose every 7 days, or like radiation therapy, let's cut it up, and do a certain amount every day. That's not really logistically possible at infusion sites, but this is the idea from one extreme all at once to partitioned up over the regimen time frame. And if you have a mathematical model that's mechanism-based and calibrated with the individual, then you can identify which therapeutic regimen is going to be the best for that individual person. And it may not be the same for everybody. I mean, it's probably not, right? I mean, the pipes are different. The extravascular, extracellular spaces are different. The geometry is different. So it's probably not the same. So you can use that kind of thing to try to track quantities of interest, like tumor size, that kind of thing, tumor cellularity. And here it is just with 2 different doses. This is 1 dose versus 3 doses. So like 1 dose versus 3 doses. And you can see that there's a variation between the two, which we'll unpack a little bit more in the next slide. But you can do this for a whole host of things, not just one dose, not just one regimen and another. You can do this. You can vary the dose along one axis and the schedule on another and make this surface where the vertical axis is some outcome, progression-free survival, overall survival, a combination of efficacy and toxicity, whatever your quantity of interest is. And you can make this surface. And these surfaces you can make for the individual patient because the model is calibrated on their data, and then you're just varying the interventional strategy. And what we found a lot when we first started doing this is that the standard regimen might be down here on this surface, but the one that's optimal for the patient is frequently far away from where the standard regimen is. When we first saw this, we had shivers up our spine, and this is the kind of work, this plot right here took like 10 years to make. So I hope you appreciate it. All right, so the patient comes in and they present with some physical state. You make some measurements, you populate your digital model, you track your quantities of interest and try to maximize your rewards, and then you repeat the thing. So you have the patient here and you have your model. Patient comes in, you get the measurements, calibrate your model, make a prediction for what the intervention should be. That tells you how to intervene over here. You do that, that changes the system. You make more measurements, update your model, and the cycle repeats. And that's that back and forth between the physical and the digital is the key thing to the digital twin. Right. So I want to zoom in on this just for a second here. Right. So that's just literally a zoom in of the plot on the previous slide. So with this kind of nonsense, you can simulate 2 drug schedules to determine which is better, right? But you don't have to stop at 2. You can stop at dozens. So here's that A, C, and T therapeutic regimen for triple negative breast cancer. This is the chemotherapy backbone. And you can vary, same total dose. You can just vary the way that it's given. And you get this surface. Every vertex here is a different duration of Taxol and a different direction of AC and a different corresponding final tumor burden. So everything that's above this gray, I hope you can see that the gray horizontal plane, everything above that, we would predict the patient would have significant residual disease. And everything below it, we'd say that they'd have a chance for pathological complete response. So this up here is what the patient actually received, this combination of AC and Taxol. These, I don't know, is that teal? These teal dots right here, those are standard of care options that the patient could have received. So we see this in a significant fraction of patients where we identify other therapeutic interventional strategies, same total dose, same drugs that we predict would have better patient response. So we use this type of analysis for some set of 105 patients and try to optimize their adriamycin, Cytoxan, and Taxol schedule from 120 different options. And we found that we were able to, at least in theory, improve the pathological complete response rate by, upwards of 20%, right? So that's just in theory. That needs to be tested. Similar idea for radiation therapy, right? So here, this is the standard of care dose map. Now that I'm looking at this, if you're not used to looking at this, this is not very helpful. This is a zoom in on the dose plan for a glioma, right? And so the higher the intensity, or the brighter greens are, each pixel tells you how many gray were delivered per dose, right? And so this is the standard of care dose map. Using our modeling nonsense, we then find the areas that we think are highly proliferative, and we adapt the dose based on that. And so this is the adapted dose plan we want to give this patient, right? And so here's the pre-adapted therapy. This is the tumor from a handful of visits beforehand. We use this to calibrate the model, and then we can go one of 2 ways. Here's the response predicted for standard of care, for the standard of care dose map, this thing over here. This is the tumor burden after 7 visits. And the predicted response adapted map based on this right over here, where you're adapting the dose map, the radiation dose map, to where you think the areas of proliferation are. So you can see that this certainly has lower tumor burden than this, that's quantified in this map over here. This is the standard of care treatment, this level of tumor burden, and then everything's normalized to that. And then this is what's in what our one is in theory, and then you take our theoretical one and you pass it through a dose planning software module like RayStation or something, and this is in theory, what we think we could do better. So that's a pretty big delta. So this, of course, has less tumor burden than this over here. But you can also see that from our modeling and our prediction, there's this area here that we're not quite capturing. And so there's something going on over in this region over here, corresponding to this beast right here, that we're not capturing in the modeling. So there's certainly room to improve, right? But boosting dose to areas where we predict they're going to be highly predictive, we achieve at least in theory, median improvement in tumor control of about 25% in an initial data set. All right, so a nice thing about this platform is that it's readily testable. So here, I think this is my last bit. I think there's only 20 slides. So if you're bored and ready to sign off, there's just a few more slides. All right, so in this mouse model of HER2-positive breast cancer, we identified these therapeutic regimens involving a targeted therapy, trastuzumab, that's designed to hit HER2, and the broad-spectrum chemotherapy, doxorubicin. And we had two different things we wanted to explore. We wanted to have earlier and greater tumor control, and that's what's here. So we ran a series of experiments, and we had 6 different treatment arms, and the magenta here, I guess, is the group that had the best response given a particular regimen of trastuzumab and doxorubicin. So we used those 6 arms, calibrated a model, threw optimal control theory at it, and found an optimized treatment that was going to give us earlier and better response than the best experimental one we tested using the same total dose. So same total dose, but earlier and better tumor control. And the other thing is you can say, okay, well, we're pretty happy with this level of tumor control. Could we use less of the broad spectrum chemotherapy? So again, same idea. You have your mathematical model. It's calibrated on those 6 different interventional strategies. Use optimal control theory to find a interventional strategy that you think is going to do the same as your best experimental, that's the magenta, but use a fraction of roughly half of the doxorubicin dose. So actually almost 60% less of the broad spectrum chemotherapy. So that would be really cool if you could have the same tumor control using, 60% less of the total chemotherapy dose. And these things are readily testable in a mouse model. So this is the same stuff I had on the previous slide there, just reminding you that there's 2 things we're trying to test here, right? And so here is a study that we did with our colleague Anna Soraisi at UAB. So 8 mice in control, 11 standard of care, and 12 had their optimal control theory designed interventional strategy. So here's progressive disease. Of course, most of the controls progressed. And then here's stable disease, partial, etc. There's a lot of things on here, but the overall goal here, sorry, I'm looking at the clock, 18% response rate for the standard of care versus 50% for the optimal control theory. And of course, the key is that the OCTT achieved this using only 44% of the standard of care dose of doxorubicin. So what we did is we ran a bunch of experiments, had 6 different interventional strategies, built a mathematical model, which I didn't show you. It's an ODE system calibrated on that data, then used optimal control theory to find the optimal interventional strategy, and then went and did those experiments and found that we could achieve a much better overall response rate with the optimal control theory interventional strategy using only 44% of the broad spectrum chemotherapy. So we're pretty excited about that. All right, so here we go. The point of all this is, if you want to design something that's useful for an individual patient, you really got to rely on their individual characteristics. Using the population-based averages and so forth is only going to get you so far. I actually no longer think there's any significant technical limitations to getting these digital twins into the clinic, in the sense of using a mechanism-based model calibrated with an individual patient's data to make a prediction and guide the intervention. Like, I feel like technically we're pretty much there. But how do you deploy it in a practical manner? These are questions that keep us awake at night. We have ideas about these, but if others have thoughts, I'd love to hear them. So how do we deploy this in a practical manner? How do you get physician and patient buy-in? How do you explain to a physician that your mathematical model is saying do X? How do you explain that to a patient? How do you logistically make these things happen? How do you get the data off of, in our case, the PACS system onto a server to do the analysis and then upload it back? How do you write a digital twin report? How does that compare or complement a radiology report or a pathology report? What are the first use cases? Where's the low-hanging fruit for doing this? These are all questions that we need answers for. These are the people, of course, who do the work. I just sit in the corner and cry about funding. I highlight a work by Ernesto Lima. That was the OCT stuff in the mouse. Dr. Wu does a lot of the breast cancer work. Hugo and David do a lot of the brain cancer stuff. Guillermo does the prostate work I alluded to, and also is just brilliant and helps us with everything. So thank you very much for your time. And if you're interested, I'd love to chat about it, but thank you very much for the opportunity.
There's two questions in the question and answer. The first one is for the triple negative breast cancer data that you showed us the animation of with the treatment pulsing. Do you find that the number of cell number and perfusion number are sufficient to compare your spatial model with the clinical data, or does reducing the dimensionality from spatial components of your simulation give a richer description of the treatment outcome?
Yeah, so in that animation, we did exactly that. We took the three-dimensional maps we have of cell density and perfusion, and that was just a schematic. But the model is calibrated in 3D, makes a prediction in 3D, and then we try to look at the comparison between the 3D map that's predicted and the one that's observed. For that little animation, it was really more designed as a teaching thing to give the idea of what we're doing. But when you go from the 3D maps to those single time courses, you lose a lot of information. Now, doing the 3D calibration takes a long time. So we most recently have done this thing where we take the images themselves and divide them into habitats, if you're familiar with habitat imaging, and then calibrate on the habitats. And that seems to give us a nice balance between just using one time point or one data point, one measurement at multiple data points versus all the voxel locations at all the time points. It's a happy medium in between. So that's the one that we're kind of pushing on now. And also it calibrates a bazillion times faster. Have the parameters, specifically the proliferation and the efficacy and the B sub n, the waning of the efficacy, have they been calculated for each subtype of cancer? Yes. So we have that tabulated for the different disease subtypes. Are there types of cancer that monitoring suits particularly well? Boy, yeah, that's a fantastic question. And the short answer is we have in the subtypes for the breast cancer, there were 91 patients, 3 subtypes, and it's not weighted equally. So we don't have enough data to be able to statistically say if our alpha sub n and k of x maps are different between the 3 different groups. If I'm shooting from the hip, my guess is that we're better for the broad spectrum chemotherapies than the targeted drugs, because our estimate of drug delivery is given by our measurement of the contrast enhanced MRI, and that's a small molecule that gives us the signal in the contrast enhanced MRI. So the larger drugs, the antibodies, they probably do not have the same, they don't have the same kinetics as what we're using to estimate it, which is the contrast enhanced MRI data. So my guess is that will come out in as more data becomes available. That's my guess. What cost function? Did I skip anything? Okay. What cost function did you add to the model to perform optimal control theory? That's a fantastic question, right? So you have your mathematical model there, and then the big question is what are you trying to optimize? You can either optimize things like reduction of tumor volume at the end of the therapeutic regimen, which we did first, and this is kind of funny, and I know it's the end of the day, but it's kind of funny. The first thing we did was we say, okay, we want the tumor volume to be a minimal at the end, and we didn't think any further, and we put that in, and of course, the integral that you're integrating and optimizing over says, well, then we just need to put all of the drug at the very end, right before you measure the total drug, the total volume at the end. So it outsmarted us and it completely cheated. So then we moved to, we want to maintain, we want to have a balance of tumor size at the end, and then the average tumor size over the course of the therapeutic regimen should be minimal as well. So that's kind of where we landed. Using the model, have you tried how to optimize the therapies? If yes, are the optimized therapy the same as clinical treatments? So I guess I did not do a good job of explaining that, because there was some, I'm not sharing anymore, but the one where we did, I said that we had about a 22% improvement in theory using an optimal dosing pattern for the triple negative breast cancer. And then there was roughly a 25% improvement in theory using the optimal radiation dose plan for the brain. So those are conjectures that need to be tested in a prospective trial. So those are things we've done in simulation. So those 22 or 25%, depending on if it's breast or brain, in those cases, they're very different than what the standard of care regimen is. But for each one of those cases, there are patients for which we could do no better than what the standard therapy was, which we were bummed with at first, but then it's sort of obvious in hindsight that you're not going to be able to, just by changing the schedule and the delivery, you're not going to be able to rescue everyone. But so yeah.
Tom, quick question. Last time I talked to you, you were running clinical trials already, or what's the status on that?
Yeah, the status of that is we are still the one that we're going for first is the short answer is no, I don't have that. The longer answer is we're trying to ramp this up for radiation therapy. We have a fantastic collaborator in Caroline Chung at MD Anderson. And, radiation therapy, it's kind of the notion of changing the interventional strategy is kind of already in the ethos of the community, right? Because they use imaging to guide a radiation plan. And it's based on, anatomical stuff, the enhancing versus not enhancing. The idea of using a model to guide the intervention is just a little step away from what's being done now. So we think that's our low-hanging fruit. The first thing we're going to do is do it in stealth mode, where we, you get the data, you do your prediction, and you come up with a one-page report that you then present to the treating oncologist and say, is this helpful? Would this guide your intervention, not for this patient, but in the future? How would you want this data, presented to you? It's actually been really hard to get it funded. The first time we did this, we said we're going to do a prospective standard of care versus the optimized intervention strategy, and most of the docs we talked to said, slow down. I am not changing the interventional strategy, on a patient-specific basis. So then we backed off and said, okay, what if we just tip our toes in the water and we do what I just finished saying about the stealth mode? And they're a lot more engaged in that. But then the funding agencies don't like that because it's not as definitive as an answer. It's more of a step. So we're kind of in this chicken and egg situation.
Interesting. Yeah. Okay. Thank you.
Okay. Are we done, or there's one more?
Yeah, if you don't mind, can you elaborate on what the bottlenecks actually are in deploying the digital twins? Is the main issue in gaining more confidence in mathematical models?
I think I think it's, what do I know? I don't know anything, but my sense is that it's more it's more social than it is logistical and technical. It is getting more confidence in mathematical models. It's how do you communicate the results of your mathematical model in a way that treating clinical team can have confidence in. I feel like those are the bottlenecks, and you have to have a use case that gets you from retrospective and theoretical improvements to a brass tacks in one case where you have a success. So that's what we're going for with this radiation therapy for glioma. Yeah.
Thank you so much. Really appreciate it. If there are no other questions, this Dr. Yankeelov was our last speaker, but not least for the day at least. And we will resume tomorrow at the same time, 10 o'clock Eastern time. Today we heard a lot of exciting presentations about digital twins that are already being put into practice, including Dr. Yankeelov's cancer digital twins. We learned about the different set points and baseline immune statuses across different populations and individuals. Tomorrow, we will continue along the same lines. We will hear about modeling a SARS-CoV-2 replication in the morning, as well as from Dr. Shai Shenor on immune monitoring. We will also hear more presentations about digital twins that are, again, being already deployed in the field, including automated control for type 1 diabetes. We will also hear about other communities, in particular in Europe, that have been formed around immune digital twins and medical digital twins. So please make sure to join us again tomorrow. And with that, James, Ellen, are there any other follow-up questions, comments?
No, hope everybody enjoyed today. I put a link to the program that you can check out for tomorrow. And yeah, please come back.
James, any concluding words from your end?
Well, I think what's impressive to me is how consistent the message has been from all of our speakers. We come here with very different backgrounds, very different scientific and medical interests, and yet we're converging on an idea about how to move forward on digital twins that I think is really consistent and valuable. And I think ending with Tom Yankeelov's talk, where he's saying, it's not so hard to do it, you can do it. The problems are more social and institutional than scientific. That's a wonderfully optimistic way to end the day.
Absolutely. All right. Thank you, everybody. Thanks to the speakers. Appreciate your time, and we will see you all tomorrow.